What's going on, Code listeners? Dr. Andrew Fix back here for another episode. Thank you so much for tuning in, however, you're chiming in on this podcast, listening to this episode of The Code. And I think you guys are in for a treat. We have an awesome interview lined up for you guys. Hallie Woods and I were just talking off air about the healthcare system and why it's not serving you as the consumer. Hallie is the CEO and founder of an organization called Accessum Health, and she has spent many years as an executive in large corporate hospital systems. And recently, before starting her own organization, she was the chief operating officer of a large hospital here in the Denver metro area. Hallie, thank you so much for joining me on this episode of The Code.
It's my pleasure, Andrew. Thanks so much for having me. I'm
Absolutely.
excited to talk about this topic because it's something I'm really passionate about.
Yeah, yeah, you and me both. I think I asked Chat GPT recently to roast my personal Instagram page, and one of the things it said was this like topic around how like you're passionate about telling people about the issues with the healthcare system, and yeah, I think that is true. But can you do us a favor, everyone that's tuning in to listening to this episode? Can you just do a more thorough introduction of yourself, Hallie? Tell us like where you're from, who you are, and then we'll get into this healthcare system conversation.
Absolutely. Well, I am Hallie Woods, Colorado native, born and raised. And as Andrew said, I had a previous career before I got into healthcare, but spent the last about 18 years in healthcare, 15 years in large hospitals, and was most recently chief operating officer at a large hospital in Denver. We had about 2,000 employees, about 1,500 medical staff, and loved that job. Really got to see and meet a lot of really fantastic people who showed up every day to take care of people and were in it for the right reason. People like ultrasound techs, physical therapists, occupational therapists, physicians, administrators, housekeepers, maintenance techs who fix the toilet in the hospital room. And really, really loved that job and the people, especially during COVID, as we all know. Hospitals were really on the front line, and I saw a lot of amazing people show up and literally put their own life on the line to take care of people. But what I really saw working as an executive, working in the system, was just how the system is designed. People always say it's broken. I don't say it's broken. I say it works as it's designed to.
Mm.
Really is this very complex, overly complex system that makes it challenging for people to get good preventive care, get care when they need it. And it's really designed for profit, unfortunately. And so I left to start my own company, Accessum Health. We're a vertically integrated membership based healthcare company, and we do everything from primary care, advanced prevention, nurse navigation, kind of coordinating people's care, helping them find second opinions when they need it, helping them fight insurance, helping them understand what their doctor just told them in that 10-minute visit. And then we provide specialty care where you get extended time, rapid access when you really need it. So, in many ways, I'm trying to, can't fix the whole system, but try and kind of put the grout between the tiles for people so that they can access better healthcare and get better healthcare outcomes.
Yeah, yeah, I love that because at the end of the day, any of us providers or those many different medical staff members that you mentioned were at the facility you were at, like that's what we want to do. We want to help clients get the outcomes that they're after, and we can only operate within the system that we're playing within. Let me ask you a quick question that just came to mind. You said the healthcare system operates and functions the way that it's designed to, and that it's designed, like many other businesses, for profit. So is that a bad thing at the end of the day that it's designed to generate profit?
I think that's a very philosophical question that different people can answer different ways. I think what I've seen in healthcare and what I would argue is, and I'm not arguing for any specific, whether it's socialized medicine or medicine that works in a capitalistic environment. There's all different models, and I don't know that I can say this is the right one that's going to save everything. Everything has its own issues. The challenge I've seen with healthcare and it being again, I would use the term business of medicine. And healthcare is two different things, right? And there's people that want to play in both spaces, but the business of medicine is designed to optimize profit. It's designed to provide care for the sick, and it's designed to figure out how do we get more people into what I call the healthcare funnel, which unfortunately causes a number of different issues, whether that's a 12-minute visit with your primary care that really doesn't dive into long-term issues and health things that you should be thinking about at 40 so that you're living a healthy life when you're 80, whether that's backlogs of patients trying to see a specialist because they need to see a specialist and they're being told it's 5, 6 months, or go to the emergency room, or people just not being able to access care because their insurance company says, well, this is an algorithm that says that this is how you get the care. Again, because insurance companies are designed to figure out how they can maximize profit, and unfortunately, this means that people, the more money they save on their members, the more profit they can keep. So I want to point out that there's no bad actors. I don't want to say that there's any individual one person that's causing all of the issues that we're seeing with healthcare, but the system, again, focusing on profit and focusing on volume and throughput and money savings, ultimately doesn't help for great outcomes for you as the patient.
Yeah. Yeah. Let me tell a quick story kind of on that. And
Yeah.
I will say, as a caveat to this, I've had a relatively short career at this point. I've been out of physical therapy school for 10 years, but I have worked in a couple different settings now. I've worked as a physical therapist in the traditional outpatient general and outpatient orthopedic setting as a member of a facility that's in network with insurance, like a largely in network private practice. I've worked in clinics that are affiliated with hospitals and on the campus of hospitals. I've worked in the inpatient acute setting doing physical therapy with clients in the hospital, in their whatever wing they're on or whatever floor they're on based on their issues they're dealing with. And in the insurance-based model, again, not to say that like insurance is the only issue with the healthcare system as a whole, but in the insurance-based model, one thing that I distinctly remember, particularly on the outpatient side of things, which is where I have spent the majority of my career, is most physical therapists have a salary that they're paid, and there is a productivity bonus that is offered on whatever frequency, monthly, quarterly, depending on the organization you're for, that is based on the billable units that you charge. And however many units you charge per on average per day or per month or whatever, there's like tiers set up in a lot of these organizations where you get a bonus based off of the units that you charge. So you're literally incentivized to bill more to each person and maximize the billing that you can do so
Mhm.
that you get paid more money, right? Everybody wants to be paid more for the work that they're doing, especially if it's not going to take them more time. One thing that happened in my very first year out of school was I saw how this was playing out in the clinic with the different therapists. And I saw, like, we didn't have a policy per se where the client stuck with the exact same physical therapist throughout the duration of their care. The client would see a different PT in the office depending on the day that they came in and the time that they came in. And how we would determine who they were going to see was how we could structure and organize the schedule to maximize the billing, right?
Mhm.
So, myself being the new grad physical therapist in my first year out of school, I was watching and then finally became aware of why this was happening. I was watching some of the more senior therapists in my clinic intentionally pack their schedule with all the clients that have the commercial insurances, the United Healthcares, the Blue Cross, the Anthems, the Cignas, and leaving myself and the other new therapists with the more government-based insurances, the TRICARE, the Medicare, the Medicaid, so that they could overlap the billing and maximize those and get as many units as possible, while we could not overlap the billing with those government-based ones, and we wouldn't receive a bonus, and they were
Mhm.
maximizing their bonus. And then eventually, what ended up happening is I called this out and called it out from the lens of like, these are my clients. I want to continue to follow up with them. I don't want them seeing, six different therapists over like their first seven appointments. And that individual ended up no longer working there. But but it was because I like was the squeaky wheel that like I wasn't going to put this little issue to rest until I felt like we had a good resolution. But then fast forward, I mean, what was I doing? I was trying to maximize the units that we could bill in our clinic because I wanted to receive a bonus too. Once I
Right.
understood how the business of healthcare worked in that physical therapy setting. Um, so yeah, like people would always ask us, well, why does one appointment cost a different price than other appointments? And that's one of the reasons why. It's like you might
Yeah.
literally do the exact same things when you go to physical therapy from one visit to the next, and your bill or your charges for that session might be different. And it's because of how the facility and how the providers are trying to bill that visit to maximize the units that they can bill on a given day.
Yeah, I mean, I hate to say this, and I think that's probably why a lot of reason that you probably changed the model you worked in
Yeah,
and the
totally.
model that I worked in. But I was a COO and had physical therapy and occupational therapy, the therapy, speech therapy rolling up to me. You know, the one thing that I see is these types of modalities, therapy, for example, can be really impactful on a patient's life. They're typically not paid for or reimbursed by the insurance provider very well. And so you're really trying to run, a volume game. We used to very similar inpatient side on the hospital side. You need to see so many patients a day. You need to output this much.
Yeah.
And that doesn't account for the fact that one of our occupational therapists might need to see an 88-year-old stroke victim who has multiple things. Like maybe she doesn't have somebody at home. And so she's trying to coordinate, well, how are we going to get her therapy when she leaves the hospital? But that type of work doesn't get extra, when you have to do that extra work, it doesn't get a billable code. And that's where I think a lot of these problems lies. There's billable codes for everything. So we're all trying to code up, manipulate the system to get those billable codes. But a lot of really important work doesn't fall within those billable codes. And that's coordination. That's the government payers, like you said, a lot of times they have their Medicare when they're a senior that have multiple comorbidities that need extra support, or maybe their socioeconomic determinants of health are impacting their health, and so they need more support. And so, again, we don't necessarily are able to tie a billable code to everything we do. But what you're saying about physical therapy and those upcoding, we did the same thing in the hospital, and it's playing the game, right? It's not fraud. People aren't going and looking for things that aren't there, but we're looking at, well, if they show this symptom, we can say they have this. It happens in hospitals, it happens in outpatient settings, it happens in Medicare Advantage insurance plans where people say they're sicker, so I can get more money for this patient because you happen to show this symptom, so now I can upcode you. So again, a system incentivized to push more billable codes.
Yeah. Yeah, it's the you just play within the bounds of the game that you're playing is the way that we typically will describe it. And like you said, that is one of the reasons why I decided to make a change, no longer work in that setting. You decided to make a change, no longer work in that setting. And that's why Physio Room operates the way that it does, where we're not treating people like they're the diagnosis or the condition that they have, because like you said, each individual person is going to have their own individual set of circumstances that impact what's going on. They might have a strong social support system, they might live alone, they might have a lot of comorbidities and they went through a knee replacement, they might be totally healthy otherwise and very fit and active and they went through a knee replacement. Like those two individuals are going to respond and recover much different. But the provider is gonna try to individualize that to them the best that they can, and like you said, bill things the way that they need to in order to try to make it work. When did you or where did the idea for Accessum Health come from? And like when was it as you're working as the COO of the hospital? Like where did you start to come up with this idea like this isn't working. I have this other idea, and then you decided to make that into a reality.
Yeah, it's a multifactorial answer, Andrew, and some of it's personal things that happened to me. Some of it is just seeing the system and what I was doing to help other people. So, a couple things. my mom, she was a nurse. She was a nurse for 30 years. She was probably the first healthcare worker I ever knew, and really was the reason that inspired me to go into healthcare because I got to see her as a nurse. You do so much more than clock in and clock out, and you're taking care of people when they're really vulnerable and they really need you. And my mom was 62 years old and healthy and was kind of complaining of some shortness of breath and some chest pain. Went to see her primary care. Primary care in his 8-minute visit kind of said, "Oh, you're probably fine." And 3 months later, she died in her front yard of an unknown cardiac condition. And I got a call. And that time I really thought, like, how did we get to this? She was a responsible person who tried to use the healthcare system. Then myself, because of that issue, I was driving down the road and having some chest pain. And because I seen what happened to my mom, I got into a cardiologist. I advocated that I wanted to get all checked out. I wanted labs. I wanted scans. I wanted to do everything to check out young kids. And in all that, my heart was fine, but I found out I had early stage cancer growing. And I'd just been in my primary care doctor's office 30 days prior. My labs were normal, it all checked out in my 10-minute visit. And I was the person that should get access. I work in the system. I had a good insurance plan. I know doctors. And I was just thinking, our system really isn't designed for health. It's designed to get people who are sick. And I, working in the system, would have friends and family call me all the time saying, "Hey, this happened. I got this diagnosis and I can't get into anybody. Can you tell me, like, who should I go to for a second opinion?" Or I am just got this bill. I had a friend call me one time and say, "I got this massive insurance or medical bill from a hospital I was at. I fell from a ladder. I went to the ER. They did a CT of my chest because they thought I had some broken ribs. And then I got this out of my pocket $800 bill for a head CT. I don't think I had a head CT. I didn't hurt my head." And the hospital keeps saying, "Hey, you owe this $800. Nope, it says in the chart you had it." And I said, "Let's get your radiology report and let's see if the doctor actually read a head CT." Nope, wasn't there.
Mm,
And so just those little things that we were doing to support people, and then just seeing a system that was really not designed to help people be healthy and help them navigate the system, including myself. I just said, I can't keep working in this. I've got to do something better, and I've got to find a way to scale the support in providing better care, like what Physio Room does, but also helping people navigate the system differently. And it can't be just because you're a friend or a family member. How do we make this scale to other people who need the support?
yeah. Yeah, that brings up a question because I sort of agree with you. Like, if you walk in to see your physician, your primary care, whatnot, because of your experience, you know a little bit more of like what questions to ask, what things to bring up in order to kind of like steer your experience
Mm-hmm.
and kind of like manage your own health and make sure you get the tests and things that are necessary. But to somebody listening to this who maybe, doesn't have that, how would you recommend they approach things if they're the one or their family member's the one like going in to see their doctor, their
Yeah,
physician? Like, how do they make sure that they can like take control of their health to get the necessary tests, to get the necessary screenings, to see the necessary specialists so that things don't get missed that they didn't even know about because they're just following along with whatever their
yeah,
doctor told them to do and they don't know any better.
yeah. Well, I want to answer that question because it's something I'm passionate about, Andrew, and I'd like to help people with that. I'll tell you some tips, but I kind of want to back up even a little bit and explain the economics of why that is the way that is. Because
Yeah, I think that
I
would
think
be great.
a lot of people like walk in and let's just go something as simple as the primary care visit, your annual visit that you go in for your wellness. And I think whether you're 20 or you're 80, you should be doing that. Um, but the economics of the healthcare system are such that, so we have a large hospital healthcare system. Hospitals, they own physician practices, they own outpatient surgery centers. And if I know as an exec in that system that I'm going to make about $130 for the visit of that primary care doctor, That's going to be my top line. So that's going to be the revenue that comes in. That changes based on insurance, but just on an average perspective, I have to pay the doctor, I have to pay the staff, I have to pay the lease. So you can just look at that's not a lot of money, not a lot of margin. Now, if I go on the hospital side and I think about somebody who's going to have a cath procedure, a coronary cath procedure, so that's done where a wire goes into the heart to either treat a heart attack or prevent a heart attack. I know I'm going to make about $12,000 to $60,000 on that one little procedure. So just kind of doing the math and thinking about that all the way back there. If I know 100 primary care visits yield about 3 visits to a cardiologist, a heart doctor, and then one of those patients is going to get to my cath lab, I need to backtrack that all and say, how do I get more people in that funnel? How do I get more referring to the cardiologist and then more to my cath lab where I really make the money? So what do? I go to Dr. Jones. Hey, I know you're seeing 25 patients a day. Your slots right now are about 12 minutes. Let's bump you down to 10. Let's get you up to 30. And we can really just have the MA do everything. You come in, see the patient, go right out. I can double book appointments, and we did this. Let's put 2 people in the 9 a.m. slot. Sometimes people don't show up, and if both show up, we'll just work it out. The doctor will be a little late to the other one. Um, and what happens during that time is you get that 12-minute, 10-minute slot with your doctor. They don't talk to you about things like family history, trended labs. We look at how does your cholesterol look at this moment of time? Oh, it's in range. We don't look at did the last 10 years, is that heading the wrong direction? Um, One fact I heard from a weight loss physician who said metabolic disease actually happens for 10 years prior to someone becoming pre-diabetic or diabetic. And
Yeah.
so if you just think about we're all trained in our 10-minute visits and the way insurance reimburses to now only treat the person who's pre-diabetic, not the person who's pre-diabetic. And so what I like to tell people to answer your question, Andrew, is you got to take more control of your visit. If you've got 10 minutes with your provider, how do you frame the meeting? And some of this is stuff that you think, well, I shouldn't have to do that, but it is what it is. And so this is how you can control your health. We have a sheet we use that I use and that we give it away free on our website. But at the top, I always say put three important health goals, things that happened in the last year you want to talk about, something you're concerned about. Put some family history. If you haven't already talked about family history, list grandma, mom, heart disease, cancer, these types of things. Put it right in front of them. I track my labs in a quick little table. Let's look at our cholesterol. Let's look at our hormone. Let's look at some of the things over the last 5 years and put it in front of the doctor and say, I notice it's going up. What are your thoughts about it? I always advocate to see a specialist. Primary care are wonderful, but when you have an issue with the heart, if you've got heart disease, go talk to a cardiologist, have an echo done. And a lot of this can be approved through insurance with family history. You just got to, again, advocate for yourself. Don't wait till they say, well, maybe we should send you out. Um, and so I think, as humans, we're designed to trust our physicians, our providers, because they have all the schooling. But unfortunately, you need to be your own advocate. You need to push and ask for things because sometimes in this quick system, it's, as you said this before, the squeaky wheel gets the oil, and you've always got to be the squeaky wheel when it's you or your family's health.
Yeah. Yeah, totally. And I agree with you 100% that it may feel like why do I need to do this? Or you don't think you should have to do this, or you don't want to do this. But at the end of the day, you have to if you want to get the care that you're looking for in the way that the system is designed. Because though it's not the provider's intention, in a 10-minute appointment, the provider is a little bit stuck in like what they can and can't do. Like they can't uncover all the rocks in 10 minutes, especially if you're not seeing them regularly. Like if you're only seeing them once every year or two, impossible for them to do that. So what I guess I'm getting at is it's not just the provider's fault that this is happening. So I'm not saying that yours or mine or anyone else's primary care provider in this example is the issue. But more so like the whole thing is the issue, what we were sort of
Right.
talking about. Um, and I think that the big point, like you've mentioned a few times is that the system is designed for sick care, not for preventative wellness and preventative care. And I guess along those same lines, let me ask you that question of I think we have people, if you're somebody listening to this podcast, you probably fall more on the side of the spectrum where you fall more into the preventative rather than the reactive category. How can somebody try to approach their health in a preventative way if they're trying to go through the traditional medical system? How do they try to maximize their experience for prevention? Is there anything different in your answer for that?
I think it's a good question. Sometimes it means that you have to go outside of the insurance system, so you've got to find places like Physio Room and I nutrition's a huge thing. Find a registered dietitian, find people that can help with things around metabolic, cardiac health, cancer prevention. Um, and I think there's sometimes this misnomer that cash pay means it's ridiculously expensive. Oftentimes that's not the case. People try to be affordable. So I think advocating for yourself in spaces where it's not just the traditional medicine system, and advocate to see a specialist and talk about these is my family risk factors. There's a lot of things online now. I think like this podcast, there's so many great educational things, whether it's Peter Attia or Huberman Lab, or, there's just ways to get information for free that you can better educate yourself on things that you can do and proactively seek it at Accessum. We do a lot of this as well as we help guide based on what your age and health and life goals are to help you find and create a package around prevention for you. Um, the thing I also say somewhat similarly around prevention, but also around, and I think, Andrew, you probably can speak to this a lot, is if you're in the medical system, get a second opinion. I think as consumers, we tend to read, 10 different Amazon reviews before we buy $100 computer monitor or whatever it is. But before we jump into a surgery or go with a treatment route, we rarely seek a second opinion.
Mm.
And if I just think I think this is because something we can use in both of our space, but if I think about a spine surgery, going to create about $30,000 of revenue coming off of that. That's really easy to think. Then why would a hospital or a physician want to jump to that? Because again, back to what you were saying before, financial incentives. Again, not accusing physicians of doing things for finances, but the system being that way. And so that's how you very quickly can jump into a more aggressive form of treatment versus maybe getting a second opinion or doing physical therapy, doing some of the things that we actually chronic pain management. There's some less billable but more important things for people. So we just talk about prevention and kind of taking control of your health. I think getting multiple opinions is really important.
Yeah, yeah, and I've had my own firsthand experience with that from some
Yeah.
different surgeries and things that I have gone through. And I feel like, I was kind of that person that got pushed down or steered down the surgery route due to some physical orthopedic related symptoms that I was having, without even considering other options that might be possible. I just saw the athletic trainer at the school, then I saw the orthopedic, then I got the MRI, and then before you know it, football season was over and I was having surgery. And then I had another surgery. And then I had another surgery because the symptoms weren't going away all the way. But after at a certain point in there, I decided to get a second opinion. And then I got a third opinion. And then I switched surgeons to go see a different provider. And since I saw that person, I've had no issues. So I guess my point there is yes, I agree. Second opinions, third opinions. And you can kind of approach that from a different point of view. Like you could go get a second opinion and pretend like you never saw the first person and treat that like it's its own unique appointment and just see what that other provider says. Or you could also let them know that you're there for a second opinion and tell them like, hey, this is the recommendation that I was given. I want to know if you agree with this or if there are any other options that might be out there for me. Um, So, you could try that either way and see how that experience goes for you. I kind of like to, in my own experience, I kind of like to do that second opinion like separate and like
Hmm.
act like it's a first opinion. You're just seeing a different person without clouding their thoughts or recommendations based off of what you already have been told. And that's the same thing that happens when somebody comes in here to physio room. At least if they see me, like if I know they've already seen someone else, at some point in the appointment, I'll want to know what they've already done in physical therapy and what their provider thinks, but not when I'm doing the assessment. I want to assess that person without my judgment being clouded from what they've already told me. I want to assess them fresh. I want to assess them before I look at the MRI so that I can just see things with my eyes and feel things with my hands and ask questions. And then I'll take the information from the imaging reports, and then I'll take the information from the other provider so that we can craft a different treatment plan potentially than what they've already been doing that may not be working to get the outcome they want because otherwise they might not be here in the first place. So, but I
Yeah.
don't want my assessment to be clouded by stuff that's information that's already out there. And that usually goes pretty well for me. But yeah, I think, and even in our office here at Physio Room, sometimes because we're fortunate to have a decently large team at this point, sometimes we'll refer within house to each other to get another second opinion for
Hmm.
a client we're working with. Like, hey, Dr. So and so on our team, client of mine is not quite responding how I was hoping they would. I was hoping they make a little bit more progress by now. Can I get them in with you so that you can take a fresh look at them and see if you're seeing anything different than me? And I think that's one of the more powerful things that we can do is like just to make sure the client's getting what they need. Um, and we've like rarely have we not seen that approach actually improve the results that we're getting for a client. So
I like hearing your opinion as a provider, because I think that about how you want to assess your patient. I think we at Accessum we do a lot of helping with second or even third opinions, and we can do local or you can even access national that even you can do virtually.
yeah,
Um, but we always tell our patients, our clients that don't tell the provider what you could say it's a second opinion, but just don't share what
yeah,
was already there. Get their unbiased opinion. Present all the clinical information, right? It's important if you're reviewing for a surgery that they had the imaging, they have those things, but let them come to their own assessment.
totally.
And then you have kind of that unclouded, unbiased judgment. My daughter, she's turning 8 this summer, but when she was 14 months old, she had a congenital hypotonia, so her muscles were really loose, and she had hip dysplasia. So we took her to a pediatric orthopedic surgeon about 15 months, and they said we need to do a massive surgery, break both femurs, realign them. She'll be full lower body casted for 12 to 16 weeks. She'll have to have about a year of PT to learn to walk again. And we left that appointment, my husband and I, going, oh my gosh, like I can't believe we're going to do this. And then I thought, we need a second and third opinion. And so we got two really great physicians who both said, no, let's not, we need to watch her over years and let's see. I think she'll progress and her hips will form the way they're supposed to. And here we are at 8, and she's never had the surgery and it's still being watched and progressing. So, even I felt at the time, just personally, that even if she did have to have the surgery, at least I was going to be certain as her mom that she needed it. And so I think again, that's the value of a second or third opinion on something with your health.
Yeah.
So it's something I really recommend, whether it's prevention or sick care. Really important to get multiple thoughts.
Totally, totally. Yeah. Well, and from what it sounds like, I'm glad you guys made the decision to do that and not
Yeah,
or get that procedure at such a young age. Because one thing's definitely true. Once you go in for a surgery, right, or anything like that, you can't undo it. So,
right.
of course, I'm a little bit biased in what I'm about to say because I'm a physical therapist, but it is hard for me to think of a scenario that someone might be dealing with symptoms orthopedically, musculoskeletally, or whatever, where it wouldn't be beneficial to at least try the conservative management route first because you can always go have the surgery. So like say for example, somebody has a rotator cuff tear, and they get an opinion, and one physician says, yeah, we should do rotator cuff repair surgery, fix your shoulder. You'll be in a sling for several weeks. You're going to need 6 months of rehab, et cetera, et cetera. And it'll take a year till your, shoulder has regained the strength, but we'll repair that tendon. If you do the conservative route first, physical therapy or whatever that is, whether it's not physical therapy, you might be working with some other providers, a good personal trainer, or something like that. If you end up having the surgery in the future, you're still going to be better off because of all the strength and mobility work that you were doing leading up to the potential surgery down the road. It's not like you're, putting yourself in a scenario where you're like delaying the benefit or something where you're like, oh, well, I should have just had the surgery sooner. Because no, now because you have more strength, now because you understand movement better, you understand what to do, you're going to recover better from the surgery if you do have it. So, um, if it's one of those things that you get some opinions and they differ or you're kind of on the fence, it is almost never going to be a bad idea to just let's just try to work on this.
Yeah.
And if you end up having a surgery, fine. There's a time and a place to have surgery. I'm not saying nobody needs it. I've had several, and I think I'm in a better place now knowing what I know. But there's also a time and a place where you don't need it.
Yeah.
You know, we had a scenario just like this with the shoulder where a middle-aged woman that we're working with, she's the primary caregiver for her 96-year-old mom. She's got terrible rotator cuff tear, and but she's the primary caregiver for her mom, and she helps her transfer from bed to chair and this and that, get in and out of the car. Like she can't have surgery. She
Yeah.
can't do those things if she's in a sling.
Yeah.
So we avoided the surgery because she's like, no matter what the physician tells me, I can't have surgery right now. I have to be able to do these things at home. So we need to manage this a different way. So then that's what we did. We managed it a different way.
Well, to your point, Andrew, I think you can always go back and have the surgery, and surgery does have a place. Like there's just times when you need surgery, and I know a lot of wonderful surgeons who do great work. But at least if you went, as we felt with our daughter, if we went down the conservative route and surgery could be avoided, then I felt like we did our due diligence and it was the right thing to do. And like you said, you usually are in a better place before that. So I really think that in some cases there's just a pinched nerve or something where just it needs to be done. But usually with qualified professionals, you can kind of assess that and get multiple opinions and figure that out with the right care team around you.
Yeah. Yeah, totally. Um, I had another question for you.
Yeah.
It's sort of escaping me here. I asked you like sort of where the idea for Accessum Health came from, and you sort of told us about this multifactorial answer. Um, prior to starting it, had you been familiar or become aware of any other organizations like this that had started, or is that why you just decided to start this in the first place?
I think we're unique. I think there's a lot of different branches of people moving outside of the insurance-based system. We still work alongside insurance, so we are working. It's hard to, if you need a cancer surgery and orthopedic surgery, to kind of go outside of that system.
Yeah.
But there's a lot of people, I think, in the space trying to provide better care. Many people have heard of the term concierge or direct primary care. That's where a primary care doctor kind of opts out of insurance and says, you pay kind of a cash pay retainer for me once a year and you get more prevention, more time with me, unlimited access. Instead of going to the urgent care, we have space for you in our clinic when you get strep throat. So those are, some of the models that I think a lot of people are more familiar with. But there's a lot of different companies kind of emerging in that space, either through care management, and even national networks now of concierge or direct primary care. I think one misnomer around membership or concierge care is that it's, only for the uber wealthy. And for a while that was the case, right? If you were an athlete or a movie star or as a pop star, you had your own personal doctor. But now we're seeing more and more providers kind of get into this cash-based space because this is an interesting stat. The average primary care doctor is holding a panel of 2,500 to 4,000 patients.
Holy smokes.
So if you always wonder, like, when you pick up and call the phone and they say, I think I have a sinus infection. Can I get in? You're told there's no appointments. You end up going to the urgent care. That's why. And so you have more and more physicians kind of saying, I can't keep doing this. I don't want to not know my patients. I want to spend time with them. I want to help them be healthy, not just treat them when they're sick. And so you've got more people kind of getting into this space of let's opt out of insurance. Let's stop having to fight to get paid for basic things and let's, set up a practice the way it used to be with less patients, but more time. And so to answer your question, yes, there's a lot of people in the space, but the vertical integration is really what we're seeing is new. Not a lot of people, once you leave your concierge primary care and you need a neurologist, you're back in I got to wait 4 or 5 months to see them. So I think we're really different in that we're holistic and we help fight insurance. We help the patients maximize their benefits and actually, help keep them out of the ER.
Yeah.
And that's a more holistic approach than what we're seeing in most of the kind of concierge space.
What if we go down that conversation just a little bit? Because I didn't ask you this at the beginning. What exactly does it mean that Accessum Health is vertically integrated?
Mm-hmm. So we do everything from the prevention and primary care to the navigation coordination to seeing the specialist. So we have a network of specialists that all of our patients can see within 7 business days. We get them in quickly, but we also get them to see the provider. So you're not seeing a nurse practitioner in place of a neurosurgeon. Again, I think nurse practitioners or PAs can be powerful tools when used in the right way. And then through all of that, we're coordinating to make sure that your prior authorizations, your approvals from insurance are in place, so you're not going to get an out-of-pocket bill for something that you shouldn't need to. So I like to say people who understand financial planners, wealth advisors, people who kind of come in and help you think about how you should invest your money and what tax breaks you should be aware of, and how do you take advantage of a small business and doing tax write-offs, and think about, well, there's different investments you can make over here with your money. And you just kind of think, well, I'm just going to call Bob, my investment manager, and he takes care of it for me. We do the same on the health side.
Yeah, got it. Got it. Yeah, that makes sense. And to go back to something that you just said about the average caseload or number of clients in a book of clients that the average physician manages is 2,500 to 4,000. It's an extremely large number, especially when you think about it in the context of, I believe, what science has told us is like the true number of like social relationships that somebody can manage is about 150. Now, and I understand patient relationships and relationships that you have socially in the community and stuff are not exactly the same thing. You don't have medical charts and things on your friends and family members necessarily. But I know that number in the concierge or direct primary care space and whatnot is like 10% of that probably. It's an extremely smaller number of clients that those providers are trying to manage at any one given point in time. And then it makes sense that you can get to know your provider better. They can get to know you better. You can have a little bit of a stronger relationship with them. And that's what a lot of people are looking for these days is a stronger relationship with their provider and feeling like they're talking to someone who actually knows and remembers them and
Mm-hmm.
understands what's going on with them and that they're not just staring at their computer or staring at their chart the whole time trying to type things while they're talking to you. So,
Yeah.
yeah, I think that's very interesting. And you mentioned that it's slowly changing the mindset or the thought that doing this concierge medicine or seeking out preventative care and whatnot is much more expensive than going about your health in the traditional insurance-based way. And that's just not necessarily a fact, right? What's happening every single year with pretty much every insurance company is premiums are going up and up and up, while
Mm-hmm.
reimbursements are oftentimes going down, right? Like specifically to relate it to physical therapy, I know this year we have been trying to fight off reimbursement cuts from Medicare, from Medicaid, et cetera, and all these other commercial insurances. And but your premiums are going up, but then what they're paying to the providers goes down. And along with that, your deductibles and your out of pockets and stuff, like I don't ever know of an insurance company that lowered those things, right? They're just going to keep climbing. They're going to be going up and up and up. So what many people are doing, particularly the ones that are otherwise relatively healthy, they're not somebody who meets their deductible or they're out of pocket on a regular basis. A lot of these people are starting to opt for higher deductible plans with lower premiums so that they can reduce what they're spending on their healthcare because they don't meet their deductible anyways. Because if you've got a $5,000 deductible, but you're not going to meet that, you're going to be paying for all of these bills, quote unquote, out of pocket towards your
Mhm.
deductible anyways. So, if you could instead lower your premium, spend the money in a different office that may not go towards that deductible, but it's going to go towards helping you prevent health issues or take care of yourself better, it may not actually cost more. It may cost less.
Yeah. Yeah, it's a great point. I think there's this misnomer too that patients have. I'm paying more in my premiums. I'm paying more in my deductible. And so all my providers are getting more money. But what's ironic is on the back end, Medicare just got cut again this year, 2.8%. And so you have physicians and clinicians, like at the physio room, who are getting less money despite costs going up, right? Our leases aren't getting any cheaper. Late people are with inflation, labor is going up. And so, I think there's this theory that all the physicians and providers are getting more money in all this. And so it's challenging because we're all feel like we're paying more money, but we're getting less care, and we are. I think there's really a way you can start looking at things differently, as you said. Like, some people are opting for high deductible plan, get an HSA, and then
Yeah.
pay for more routine care out of pocket.
Mhm.
And that's something that people can do. I was talking to someone about this in a group the other day, and someone asked, like, how do you do this? How do you figure out what the best way to pay? And it can be a full-time job, and if you're busy and have kids or aging parents and stuff, that can be a challenge. But call up and find out how much it would be out of pocket. Oftentimes I think people have this misnomer that they see their explanation of benefits or what the insurance company pays, and they think that's what they'd have to pay.
Yeah.
But these are artificially negotiated rates,
Right.
on a very complex system. And when you say, how much would I have to pay out of pocket for this dental cleaning or for this routine primary care visit, it can be much less. And so maybe something like that could be a better option for you and your family.
Yeah, totally. Yeah, we've leaned heavily into the HSA side of things over the past few years because with the exception of last year in 2024 and this year in 2025, where we will meet our deductible from having kids and whatnot. For the most part, we generally do not. And we know we're even starting to talk about next year, 2026, like, do we think we'll meet our deductible again? Like, how much will we spend on our son who's 1 year old now? What kind of bills will we accrue that are completely separate of the birth and everything of our daughter that's on the way, so that we can decide what kind of plan we want to opt into for next year. But we're still going to keep the HSA because we're
Yeah.
utilizing that money for the out of network things that we want to do, the psychotherapist appointments that we want to talk to, or the PT or the chiropractic or whatever we're doing that's not quote unquote in network, or to even cover some of those bills that are going towards our deductible and
Mhm.
whatnot that are in network, we're utilizing the HSA and a lot of times to cover those. What this kind of reminds me of, like this thought process that I pay so much for insurance, therefore I feel like I have to use the insurance for healthcare, is the sunk cost fallacy, right? It's just this idea that you're reluctant to abandon a strategy or the course of action because you've invested so heavily in it.
Yeah.
Right? It's like even though you can see that it might be better to go this other route, you're resistant to do that because you're like, no, I've already invested so much time and money on this. I have to keep going this path, even if that's not the most beneficial path for you. So, or like you force yourself to finish a book that really sucks just because
Yeah.
you're really halfway through and you're like, no, I have to finish this, even though I'm not really enjoying this book or this movie or whatever. It's like, well, you would be better off to just abandon that, move on, go find something that you do enjoy. So, we can get into that trap, I think, with our health too, where we
Yeah.
just feel like we're forced to keep going down this one path. But we can change. So don't feel like all is lost and you have to just keep seeing something through if you're finding other routes that might be available to you.
And sometimes so much about healthcare is the right fit for the provider for you that you feel like aligns with what your goals are and your values are. And finding the right person for you might not always be who your insurance says is the best option. And so, I think make the phone call and ask, what would it be to do this out of pocket? And a lot of most clinicians are in it because they care about people and they want to find a way to make it work. And um, many places have cash pay options that can help you, and you can use your HSA or an FSA if you have one through your employer on them. So there's ways that you can get affordable health care that's not like you said. Although I have to say I have definitely finished a movie I didn't like and definitely finished a book. So I
Yep.
do as I say, not as I do.
I'm right there with you. I've done both of those things. I'm speaking to myself. I'm in like two-thirds of the way through this book right now that I'm having this strong decision right now. Like, should I finish it or should I not? Because one of those books where like I already know what the rest of the book is going to say. Like it's not proving to be groundbreaking anymore. It's not a fiction book. It's a nonfiction book. I'm like, I already know what the rest of the story is, so I can just probably skip through it and save the last 2 hours of my audiobook here on something else. Hallie, I think this has been great. I think, we've scratched the surface, I guess I would say, on some big topics that I know are on people's mind. I get asked questions about this. I pose questions to clients about these things regularly. And I think we could continue to talk about this for hours, right? Like there's always going to be people that are going through decisions or challenges along these topics that we just discussed. I really appreciate you kind of pulling back the curtain a little bit from inside the healthcare system on the revenue, the expenses, where some of these decision-making processes and where some of these scenarios that we find ourselves in, 10-minute appointments with your physician, for example, like where these things have come from and how they have come to be the way that they are, because not everybody knows that stuff or will know that stuff. But I think opening up that conversation at least helps give people some context as to why things are the way that they are and how we can kind of navigate around the obstacles that are going to be presented within the healthcare system. Um, but I want to give you an opportunity to make sure if we'll put these things in the show notes and whatnot. But if somebody's interested in learning more about Accessum Health after listening to this conversation, what's going to be the best way for folks to do that and get in touch with you guys?
Yeah, thank you for that opportunity. Accessum Health is can be found online at www.accessumhealth.com. And how you spell Accessum, just little note, Accessum is Latin for access. So access being a huge component of healthcare. ACCESSUM. We have a contact us there, and we can. I talked about that one sheet primary care. We have tips on how to push back on insurance denials. So we like to be able to send those things out to people to help them. Our phone number is 303-491-0212. But yeah, really either way. And even if you just want to have a conversation on how we can help you, conversation's free. And we like to help people where they are at their health goals and where they are in life and what their needs are.
Awesome. Yeah, I'm really interested in seeing that one sheet that you talked about with the questions of sort of how to manage the meeting, as you said, like with your primary care provider to make sure that appointment you get the things out of that appointment that you're hoping to get out of it. So we'll definitely include that in the show notes. And as good of a place as that would be to potentially just end things, I want to ask you one final question. And basically, this is very, very open-ended. Is there anything that we glossed over or that we failed to mention, Hallie, that you want to make sure we cover before we sign off and thank everybody for listening?
One quick thing I'll add, Andrew, because we talked a little about healthcare insurance, and I just think this is a really important stat. Wall Street Journal recently did an article around insurance and how many insurance denials there are a year. 850 million annually insurance denials. But what's really interesting, and this is what I want to share with your listeners, because there's, when you hear these types of things, it feels overwhelming. Only 1% of people appeal because either one, they don't know how to, they don't feel like they can. Um, but 75% of those who appeal get overturned.
Hmm.
So I think, reach out to an Accessum, reach out to a friend, call the number. Don't let your care stop or the money fall back on you because your insurance company is telling you no. Again, be your own advocate. So I think that's a really important stat for people to, all of the things that we've talked about today are tough, but you're not powerless. It's helping people understand the system so they can navigate it and advocate for themselves.
Yeah, in any way we can say it, you've got to stick up for yourself. And
Yeah.
if you don't know all the ins and outs, you need to find somebody who does, right? Like none of us are going to know everything, but there are people who are experts in the different fields and in this process of like as it relates to health insurance or filing appeals and whatnot, making sure the things that you expect to get covered are going to get covered. So yeah, thank you so much for sharing that. And having done that in the past myself, receiving bills for things that I didn't expect to get bills for, it doesn't feel good. And
No.
sometimes people just pay them and they don't
Yeah.
know, and then you're out of hundreds, if not thousands of dollars, or maybe even more, depending on the situation. So thanks so much for sharing that. You
Yeah.
guys that tuned in to listen to us here on the Code with Hallie Woods, I really appreciate your time on this episode. And if you've been a Code listener before, you have probably heard me say this, but if it's your first time joining us, you'll hear me say it now. As you can imagine, reviews go an extremely long way on this podcast. So if you've never left us a review before on Apple or Spotify or whatever platform you're listening on, now would be a great time to scroll to the review section and do that. And if you have specific topics or questions that you would love to have us do a conversation on the code, make sure you let us know that too, so we can get a interview or a solo episode out about those things. So thank you guys again for tuning in, listening to us. Hallie, I hope you have an awesome rest of your day.
Thanks, Andrew. It's been a pleasure.
Thanks, guys. We'll see you next time on the code. See you later.